the beneficial of labral reattachment. Therefore, the aim of the current study was to compare the survival rate at the 10-year follow-up between hips that underwent surgical hip dislocation for the treatment of FAI with labral reattachment and to compare it with hips with surgical hip dislocation without labral reattachment. About 10 years ago, Espinosa and the team from Bern studied a preliminary study about the results of labral refixation. They could show that at an early follow-up of 2 years, hips with labral refixation had superior clinical as well as radiographic results. And the goal from the current study was to do an update on the same patients published 10 years ago, now with a longer follow-up. Inclusion criteria were hips with mixed type FAI following surgical hip dislocation with acetabular rim trimming and offset creation. The surgeries were performed between June 1999 and July 2002. And there was a total of 60 hips in 52 patients. They excluded hips with incomplete documentation, an open growth plate, or patients with an age over 40 years and hips with previous surgery. They had 2 study groups. The first, the resection group with 35 hips. Labral reattachment was introduced at our clinic in July 2001. And in the resection group, the last 35 hips with labral resection were included. These surgeries were performed between June 1999 and June 2001. Then there is the second study group, the reattachment group, with the first 25 hips with labral reattachment. They used titanium bone anchors, and the surgeries were performed between July 2001 and July 2002. We tried to follow up all the hips for at least 10 years. We could not do so within 3 patients or 3 hips. There was 1 patient in the resection group and 2 in the reattachment group. We could only follow up them for 2 to 6 years, but at the last follow-up they had no conversion to a total hip arthroplasty, no progression of osteoarthritis, and a good clinical result with a Merrill-Daubigné score from 17 or 18 points. The remaining 57 hips, we could follow them up for at least 10 years with a mean follow-up time of 12 up to 15 years. The 2 groups, they were matched for several parameters, including demographic parameters, including age, sex, weight, height, and the BMI. They were also matched for cartilage damage. We assessed intraoperatively the femoral and the acetabular cartilage damage as well as the labral damage. We used the Beck classification, and there was no significant difference between the 2 study groups. They were almost matched for the clinical parameters. They were matched for the Merrill-Daubigné score, the internal rotation, and the prevalence of the anterior impingement test preoperatively, but they were not matched for preoperative flexion. There was an increased flexion of a mean 106 degrees in the reattachment group and 93 in the resection group. They were also matched for preoperative radiographic parameters, including LCE, acetabular index, extrusion index, alpha angle, as well as the crossover sign, and also for correction. These are the same radiographic parameters postoperatively. There was no significant difference between these two study groups. And finally, they were matched for preoperative osteoarthritis. We used the Tönnis grading system, and there was no statistical significant difference. We then calculate the survival rate for each study group. We defined 3 different endpoints. This was conversion to total hip arthroplasty, progression of osteoarthritis by at least 1 grade according to the Tönnis classification, or an insufficient clinical outcome defined as a Merrill-Daubigné score of less than 15 points. So when 1 or more of these endpoints was achieved, the hip was considered a failure. And finally, we compared the survival rates using the log rank test. Here are the results. First, for the reattachment group, there was a total of 7 hips that reached one of these previously defined endpoints. There were 2 hips with conversion to total hip arthroplasty, 5 with osteoarthritis, and 5 with a Merrill-Daubigny score of less than 15. And then in the resection group on the right side, there were a total of 13 hips reaching the endpoints. There were 3 total hips, 4 progression of osteoarthritis, and 12 Merrill-Daubigny or postal score. Here are the results for the survival rates. First, for the reattachment group, we found a survival rate of 78% at the 10-year follow-up. This means that 78% of the hips with surgical hip dislocation and reattachment of the labrum had not converted to a total hip, had no progression of osteoarthritis, and a good clinical result. In contrast, the resection group, there was a survival rate of 46% at 10 years. This means that about half of the patients either converted to a total hip, showed progression of osteoarthritis, or had an insufficient clinical score. Here are some examples from the patient series. Both hips have a mainly cam-type morphology. They have a comparable morphology. They both underwent surgical hip dislocation with offset creation, and as you can see on the left side, with labral reattachment using the bone anchors. The one on the right side had no labral reattachment. 10 years later, the one on the left is preserved. There are not many signs of joint degeneration. However, on the right side, the hip with labral resection shows joint degeneration with osteophyte formation and decreased joint space, and finally had to be replaced by a total hip arthroplasty. We have several limitations for the study. First, the low number of hips. Nevertheless, we could calculate a significant difference at the 10-year follow-up regarding the survival rates. There were 7 hips lost to follow-up. We still included them for survival rate calculation up to the follow-up we had between 2 and 6 years. The comparability of the study groups, most parameters were matched between the 2 study groups except flexion. And we had to use the Merrill-Daubigny score, which is a rather unspecific score for hips with FAI, but we had to use it due to the retrospective nature of the study. This is the current literature available and evaluating comparative results between labral resection and reattachment. The first study is the previously mentioned studies from Espinosa, and the current study is an update of the same 60 patients. Then there is one other publication about open surgical treatment of FAI hips. It's from Lode. He could not find, and he was the only one who could not find the difference between labral reattachment and labral resection. All the other studies report on arthroscopic results, and they uniformly found improved clinical outcome using the Harris hip score for the hips with labral reattachment. So in conclusion, we could show that at a 10-year follow-up, 78% of the hips with labral reattachment had a good clinical result, no progression of osteoarthritis, and did not convert to total hip arthroplasty. In contrast, only about 50% of the hips with labral resection reached this result at the 10-year follow-up. And the results support the knowledge that the labrum is important for good long-term survival in hips following surgical treatment of FAI. Thank you for your attention.